Good afternoon. Welcome to Wellbeing Trust December Healing the Nation webinar on Levers for Action, Federal and State Opportunities for 2021 and beyond. My name is Ben Miller, and I'm the Chief Strategy Officer for Wellbeing Trust, a national foundation focused on advancing the mental, social, and spiritual health of the nation. Thank you so much for joining us today. And what a time to join and talk about our future and mental health, especially in the policy sphere. Our entire country has learned the power of mental health, even as we zoom into this webinar. Each of us are dealing with situations and emotions some of us have never dealt with before. COVID-19 has forced us to face a level of uncertainty that most of us have not experienced. And what a better time than now to begin to place mental health and addiction care in the center of our priorities and invest in comprehensive solutions that can help us. That's what today's about. What's happening in mental health and health policy, and what are the most promising solutions to policy for where we could go? One of my mentors, Dr. Larry Green, always drilled into my head the importance of defining policy. He described it as movement in a direction for a reason. And policy helps codify and maintain our direction. And I think that many people would consider our current direction as the wrong one for mental health and addiction. The data don't look great. And we've seen increases in depression, anxiety, suicidal ideation, and even overdoses. And if you've joined our webinars before, you know the importance of our country tackling these deaths of despair, and how the solutions have got to be more comprehensive and integrated to be truly impactful. So today, while we wait to see what next appointee might happen by the transition team, let's be reminded that we're going to need a strong outside game to complement the inside game of DC politics. Policy to local, state, and federal level should be our focus. And that brings me to today and our excellent speakers. Next slide, please, Alicia. We're going to start with David Lloyd, who's a senior policy advisor at the Kennedy Forum. David focuses on a range of mental health and addiction policy issues, but has devoted most of his time to improving the enforcement of the federal Mental Health Parity and Addiction Equity Act and state parity laws. And if you didn't see today, some amazing news from the Kennedy Forum on some model legislation on parity that I think David will talk to us about. Next, we have Jane Beyer, who served as the Senior Health Policy Advisor to Washington State, who served as Senior Health Policy Advisor to Washington State Insurance Commissioner since January 2017. She was legal counsel to the Washington State House of Representatives for 20 years, working on a broad range of issues. And she's even run Washington State's Medicaid program and been a behavioral health commissioner. So she's kind of got it all there. And we're going to learn from Jane today about what's happening in Washington. And last but not least, we have Kana Enomoto. Kana has forgotten more about mental health policy than most of us will ever know. She was a senior advisor and acting chief of staff to the Surgeon General of the US. She's been acting administrator for SAMHSA and was appointed in 2015 by former Secretary of Health and Human Services, Sylvia Burwell. She provided executive direction and policy leadership for an agency with more than 600 employees and a fiscal year budget of over $4 billion. She's currently a senior expert at McKinsey. Next slide, please, Alicia. So to set the stage and to remind you why we do these things in these webinars, Wellbeing Trust has created a framework for excellence around mental health and addiction. It's the basis for a lot of the policy work that we do found in Healing the Nation. And it's driven state work with partners like United States of Care and local work with partners like the de Beaumont Foundation. On this slide here, which you've seen 100 times if you've been a part of our webinars, you can see the framework that we've put forward. And we call it a framework for excellence because it brings mental health to the places that people show up with mental health needs. And if COVID has taught us anything, it's that we have to be more nimble when we think about traditional service delivery for mental health. We can do big things when we have the vision, the leadership, and the supports to change our structure, but we need policy change. So without further ado, let's get going. As a brief reminder today, we will have time at the end for Q&A. So please put your questions in the Q&A function below and feel free to chat away as well. Major thanks to Civitas for helping keeping us organized today, and I'll turn it over to my friend, David Lloyd.
Great. Thanks, Ben, for having me today. I really appreciate being here. Wellbeing Trust has really done groundbreaking work with Healing the Nation. So I'm going to focus today really on coverage and health coverage and mental health parity, which is really a critical piece of the equation, but it's only one piece. So there's obviously so much more that needs to be done, which Healing the Nation really goes into kind of the range of different policy changes that we need to make as a nation to ensure that people are getting the mental health and substance use care that they need. So on the coverage front, I did want to focus first of all kind of on what some of the scope of the problem is in mental health and addiction coverage. And one of the preeminent sources of data that we have over the last few years is from the Milliman Report. And Milliman in 2017 had an initial report on out-of-network disparities for behavioral health, but they updated it in 2019. So what we've seen, and this covers data from across the nation in every state, is it looks at out-of-network utilization across different service levels, such as inpatient and outpatient office visits, and several others, and looks at how often people are going out of network, which frankly, you don't go out of network and really, unless you really have to, given that the greater cost sharing, out of network. So in Delaware, which was a strategically chosen state, we see that inpatient mental health and addiction treatment, patients had to go out of network more than 29 times more often than for inpatient medical care, which is just an extraordinary disparity. And similarly, in Maine, that number was 38 times as often. So two different states, and but huge disparities, and really across the country, we see disparities. Oftentimes, 5, 10, even 40 times as often. And a lot of this is driven by inadequate networks. And one of the key drivers of that is inadequate reimbursement. And the Milliman data showed that primary care providers are actually paid 24% more than behavioral health providers for office visits. So some key data that shows kind of one aspect of the scope of the problem that needs to be addressed. And we think the Parity Act is really critical to addressing some of these issues. So the next slide, please. So, there was actually a major court case that some of you may have heard about over the last few years, but there was a major ruling last year and then a ruling just about a month ago in the Witt versus United Behavioral Health case, which is a class action lawsuit in the Northern District of California in federal court that covers 50,000 class members who were enrollees in United healthcare plans, and half of the class members were children and adolescents, and all the class members were denied, mental health and addiction care. So the court case, really highlighted, how United Behavioral Health, made medical necessity determinations in a manner that were inconsistent with generally accepted standards of care, which the court actually described in great detail, what these generally accepted standards of care were. And so really provides a very useful basis for kind of moving forward with mental health and addiction coverage. The idea that plans should be following these generally accepted standards of care when they're making medical determinations is actually a way to advance mental health parity, even if it's not directly through the Federal Parity Act. And actually, this case was not argued based on Federal Parity Act violations. Instead, it was that United Behavioral Health had violated their fiduciary duty under the federal ERISA statute. And so the court last month ordered a 10-year injunction against United Behavioral Health, and they have to reprocess over 67,000 claims. And they're ordered, United Behavioral Health was ordered to use a level of care criteria from nonprofit clinical specialties associations like the American Society of Addiction Medicine. So this really is a powerful case, a landmark case in mental health and addiction coverage that the Kennedy Forum has been working to use this case to advance policy, which brings us to the next slide, please. So these are simply the 8 generally accepted standards of care. I won't read them here, but I wanted people to be able to see what these generally accepted standards for behavioral health care that the Witt court identified, to see that in many respects, these are really common sense standards of care that all insurers, we believe, should be following. So it's like very common sense stuff. For example, the first one is that you should treat the underlying condition and not just current symptoms, which is often an issue where we see a focus on acuity in treatment and coverage rather than on treating the chronic condition itself. So again, we'll let you can read through this on your own time, but I think they are very valuable, generally accepted standards of care that the Witt court identified. So the next slide. So the Kennedy Forum actually led major legislation in California this year with our partners at Steinberg Institute. And it was actually enacted in September and signed into law by Governor Newsom. And it essentially puts in place the standards of care in California law and requires that insurers, follow these standards. And it basically takes kind of the use of these flawed criteria and mandates that insurers use criteria that are consistent, with generally accepted standards of care. So we were very excited to get this enacted in the nation's largest state, and think it provides a very important basis and kind of launching ground for putting these requirements in place in states across the country, but also frankly federally, given the importance of the self-insured market, which is only regulated by the U.S. Department of Labor. So I'll talk a little bit more about kind of the details of both 855 and new model legislation that we released today, along with Wellbeing Trust, the American Psychiatric Association, and over 30 other national organizations on the next slide. So these are both the requirements of 855 and also the new model bill, which is for states across the country. And essentially what we are requiring, is what we think is very basic stuff, or what should be core requirements, for all health insurance in the country, that supplements both the Affordable Care Act, but also the Mental Health Parity and Addiction Equity Act, which our founder, Patrick Kennedy, was the author of when he was in Congress. So the model bill, it requires coverage of all medically necessary mental health and substance use disorder care for all diagnoses in the DSM, which in California, this actually creates a powerful right that if care is medically necessary, as we define in the bill, using a definition endorsed by the American Medical Association and the American Psychiatric Association, that care must be covered. As I mentioned, the new model bill also requires insurers to follow these generally accepted standards of care and to use criteria from the nonprofit clinical specialty associations that are consistent with these standards of care. We also have provisions relating to out-of-network coverage when in-network coverage isn't available. California has strong timely access and geographic access standards that we utilize to basically improve the ability of people to get out-of-network care when that in-network care isn't available. We have a provision that says that an insurer can't deny care just because it believes that a public program should be paying for it, which again should be common sense, but we often see that happening across the country. And then finally, two final provisions, one relating to testing and training of the criteria and how it's used, because that's an important issue. And then there's also, it's a little bit wonky, but many states allow the use of discretionary causes. And this is also important in an ERISA context for self-insured plans, which creates a burden for patients to overcome when they're trying to fight denials. Essentially, deference is given to the insurance plan determination, and you have to show that that's arbitrary and capricious to overcome that determination and win. So I'll leave it there and allow Jane to go next, but look forward to having the opportunity to answer questions during the Q&A session.
Good morning. Thanks so much, David. So as Ben mentioned, I work for Insurance Commissioner Mike Kreidler in Washington State, and it is a joy to work for a statewide elected official who is so committed to consumer protection and to parity work that we've been doing, and also to the Affordable Care Act. Much of the work that we've been doing in Washington over the last 10 years has involved first implementing and most recently defending the Affordable Care Act. So next slide, please. I was asked to talk to you today about multiple activities that are going on in Washington State, so I'm just going to be touching on them. Some of them most relate specifically to behavioral health services, but Some of you have probably heard that Washington State is the first state in the nation to enact a public option to try to help make coverage more accessible and affordable for folks who are in the individual market. And when we talk about the individual health insurance market, we're talking about folks who don't have coverage through their employer. They might be an early retiree, they might be self-employed, and they are in need of health insurance coverage. So what you can see from this slide is that overall in Washington State, like other states, we've seen more and more insurers participating in our insurance market. We have 3 new ones for 2021. And for the first time in several years, we have at least 2 insurers operating in every county in the state. And as indicated, we've got a total of 115 qualified health plans that are being offered for 2021. And for the second year in a row, average rates have declined. They went down 3% for 2020. And actually, should be 2021 rates. The decrease is down 2.4%. But coverage is still too expensive. There is absolutely, I don't think anybody in Washington State that will argue with that. And there's also a study that's being presented to our legislature related to funding state subsidies in addition to the federal ACA subsidies. And our legislature did enact legislation in 2019 that creates what are called standardized health plans. So it's easier for people to shop. But more importantly, the standardized health plans tend to have lower deductibles, and they tend to cover more services pre-deductible. And the legislature also did establish a public option plan, and probably the most significant factor in that public option plan that's getting the most attention is it essentially says that in the aggregate, the reimbursement for providers who are participating in that plan for healthcare providers can't be more than 160% of what Medicare would pay. And that's a tough standard to meet, given the state of negotiations between health insurers and some of the healthcare providers in the state of Washington. But we did have 5 health insurers that bid and that are offering these public option plans. They'll be available in 19 counties in Washington State. We have 39 counties in total, some urban, some rural. And so we will be watching closely to see how that works. Next slide, please. I don't think any insurance department in the state can talk to you about what's been going on in the last 10 months without talking about what we've done in response to the COVID-19 pandemic. And probably the most significant action that Commissioner Kreidler took was issuing an emergency order. Fortunately, he has statutory authority to issue emergency orders when the governor declares an emergency. But he issued an order that expanded the types of telemedicine that could be used and that had to be reimbursed by insurers to allow telephone in addition to things like FaceTime and Skype that are available. That order is still in effect. And what we can say is that basically our reasons for expanding and ordering telephone as a means of providing telehealth services were threefold. Number one, Washington is a big state with rural frontier areas, and there is not consistent access to broadband throughout the state. Number two, we were very concerned about people having access to smartphones, to laptops, to tablets. And number three, we were very conscious of the fact that for folks who are suffering from depression or an anxiety disorder, for one, they might be mutable using use this of
we're having a little bit of issue here with Jane's connection. So Jane, if I'm talking over you and you hear me, I apologize. We're going to give her just another second here to come back on. Oh. If we didn't have these moments during COVID, I don't know what we would reflect back on during the Zoom webinars. So this is inevitable. Jane, are you back with us yet? Okay, I am going to see if Jane drops back out and drops back on. And let's quickly go back to David for a second. David, I'm going to ask you a question here because not to put you on the spot, but I don't want to get to Kana just yet. While we wait for Jane to come back on. When you all were working in California on SB 855, it took a lot of the coalition building to get things done. And I'm curious, what lessons you think you learned in California that could be applied to other states around coalition building?
I think you have to start early, and I think you have to do broad outreach, both to a range of different groups. So not just the usual behavioral health groups, but be reaching out to other health groups, be reaching out to community groups, and particularly in a state like California, geographic representation is very important. That might be slightly less important in smaller states, but given its size, that was really critical. And I think starting early, is important, given how state sessions, tend to work. I think we'll see that everyone's been paying much more attention, to equity, and it should have been much more important all the way along. But that equity considerations and kind of how you are, advancing equity, is critical, and you have to be involved in those conversations early on.
Thank you, David, for that question. And Jane, we lost you. You froze, and now you've got my name. So we're going to fix that and let you take back over your slides where you left off. You just got stuck there. So Alicia, if we can get back to Jane's slides. Thank you, Jane.
I'm sorry.
It's
so
okay.
It's okay. Connectivity. And I'm
good.
getting another message that my connection is unstable. So I'll try to stick with it.
All right.
Okay. So very quickly, probably the most important and relevant thing for this discussion is that we at Washington OIC have been engaged in an Access to Behavioral Health Services grant project. We actually got a federal grant back in 2018. And we have done two what we call market scans of insurers in Washington state, asking them a set of, at first, very comprehensive questions, and then in a second market scan, very focused questions focused on NQTLs and behavioral health parity. And not unlike the Milliman findings, we found significant differences that we are investigating related to things like provider credentialing requirements across med-surg and behavioral health, provider network adequacy monitoring, provider rate setting methodologies. You can see on the graph that's on this slide that we did find, like Milliman did, that med-surg physicians were paid more than psychiatrists, psychologists, and social workers when you looked at with respect to Medicare as a reference price. We were concerned about what we've seen regarding network providers and their actual seeing plan enrollees. But what I have to say about behavioral health parity right up front is that these kinds of quantitative data that you get do not absolutely say that there is a parity violation, but what they do is they let us know this is a red flag, this is something we have to pay attention to. And so we're going back to the insurers and drilling down on not only these data that they gave us, but also we asked them to do the 6-step NQTL analysis actually that the Kennedy Forum developed. And so we are going back and going to be having discussions with our insurers about these really critical issues. And lastly, next slide, please. I just wanted to take a minute and let you know that the National Association of Insurance Commissioners this year formed a new Mental Health Parity and Addiction Equity Act, or MPEA, working group. And it started out as an informal discussion among states, and more and more and more states became interested. And so essentially what we have put together is a formal working group at NAIC. And there are a number of state departments of insurance that are leading the way on parity oversight, just a few of them: Rhode Island, Pennsylvania, Illinois, New Hampshire, New York. And we also have a number of states that are in our group that are responding to new compliance, parity compliance reporting laws that have been enacted by the state legislatures. So we are sharing resources, we are educating each other. We've had presentations from Tim Clement at the American Psychiatric Association, and Dr. Henry Harbin and Beth Ann Middlebrook from the Bowman Family Foundation. We've been coordinating with the Department of Labor and CMS. And so we are hoping and we are working on having as much consumer participation in this working group as we possibly can. And so with that, I will conclude my remarks and look forward to questions.
Hey, Kana, we can't hear you just yet.
Oh,
there you are.
Can you hear me now?
Awesome. Yep. Thank you.
There we go. Great. So I super glad to be here. Appreciate all of the panelists and see many familiar friends in the participant box as well. I'm with McKinsey Company. I co-lead our Center for Societal Benefit through Healthcare, where I have the great privilege of harnessing all of the power and resources and incredible strengths of a firm like McKinsey and bringing them to bear on some of the more challenging problems in our healthcare system, looking at mental health, substance use, rural health, maternal health, social determinants, and health equity issues. So one of the things I wanted to talk about today was how we, I think when I look at the list of policy issues that are getting talked about at the federal level, I don't think they are particularly surprising to anybody. They've been sort of some of the same, plus or minus 2 or 3 items, and the same items that we've seen since the Carter Commission. But now I think more than ever, we have a confluence of factors in our favor, which help us make a case for bigger and better investments than we've ever seen. And go ahead to the next slide. And just go ahead and click through. Yeah, these are not numbers that are surprising to anyone. I think most of you all who are on the phone, you're familiar with it, but I don't know that all of our policymakers really understand the scope, the breadth, the depth of the challenges that our economy faces as a result of poorly treated or untreated mental and substance or unprevented mental and substance use disorders, and even the longer range economic impacts, like a 28% reduction in net family income by age 50 for people who experienced a mental illness as a child. These are significant and long and far-reaching impacts. And as we look at COVID and the context we're in now, the problems are only getting worse. If we go to the next slide. And next, go ahead to the next page. Yeah, thank you. So we have issues across the quadruple aim of access, affordability, quality, and experience. So I think as Beth and David talked about issues around, Jane and David, sorry, talked about issues of parity and newer, alternate payment models, value-based care, moving into how to help people afford care and access care, because we lag behind other health specialties. We also lag behind on quality, and I think there's an opportunity for us to push harder for higher quality care, for holding ourselves accountable, those of us in the BH field, but also demonstrating our value to others. And perennially, we have the challenge of experiencing societal attitudes. I think maybe this is the time that we have, 42% of Americans experience symptoms of anxiety and depression through the COVID challenge, through the election. through our spring and summer visibility of issues of social injustice and race inequities. More than 2 out of 5 Americans are experiencing symptoms of mental and substance use disorders. I think that perhaps makes them a little bit more invested in wanting to reduce the negative attitudes, the prejudice, the discrimination that we see towards these issues, towards the providers, and towards the care itself, and towards the people, obviously, and the families that are experiencing them. Next slide. So this is when, I don't know, I think there's Henry and team with Milliman had a similar paper come out. We were doing this at the earlier parts of COVID, helping people understand that even in our already commercially insured population, you're seeing about almost 1 out of 4 people with a BH diagnosis. So that's any mental or substance use disorder as a primary or secondary diagnosis. And then, but those individuals are driving 60% of the care and of the healthcare spend. So when people say, well, behavioral health, we can get parity in terms of what's being offered for BH services, people kind of hem and haw about the cost of the BH care. But the cost of the BH care is dwarfed by the cost of the physical health spend that it drives. And so it's helpful, I think, to put those numbers in context as people are considering the potential cost impact of bringing rates to parity, of making networks more adequate. Next slide. So here we see, this is a report that we did from our McKinsey Global Institute looking at health, all different domains of health, and what would happen if or what is the cost of not implementing what we know works based on science in terms of prevention and evidence-based treatment and recovery supports across all health conditions. We found that behavioral health conditions, so mental illness, substance use, and interpersonal violence and self-harm, are accounting for about 1 in 7 years of lost productivity, lost life due to poor health and premature death in the United States. Skews very young, and so the economic impact starts early and lasts for a long time, resulting in almost $1 trillion to the economy annually. So when we think about parity, I think it's important to put it in that context, that it is actually one of the leading cost drivers, the leading cost of disability across all health conditions, and yet we are making the lowest progress in terms of being able to adequately prevent and treat these conditions at scale. Next slide. So these are all the challenges that I think everyone on the call is probably very familiar with: the integration, EVPs, BH literacy, awareness, stigma, lax prevention, and challenges with our workforce. But there are, and so I think that I hope that the policy solutions we see are going to be arrayed against some of these long-standing challenges. Next slide. This is just, I put this in, this is like my data dessert. I love this slide because it sort of breaks down the cost of care and where the opportunity is as we push for better, more adequate behavioral health care. We also need for it to be not just on the deeper end, but across the board, because here you'll see we know that people with mental and substance use disorders have higher health risk. They have more health conditions, more chronic conditions. But even beyond that, the cost of their health care is sort of inexplicably higher. They're getting more spinal fusions, more knee replacements, more MRIs. And so we have some work to do to figure out what is the role of addressing behavioral health in a new world of value-based care, and how do we figure out how to attribute value and risk to the behavioral health providers specifically, because as you can see, there's just a lot of cost at stake, but even beyond the cost, there's human cost of people who are getting healthcare that's not meeting their needs. Next page. And so this is the array, I think, of the domains of where we see action that will come. I think we're going to see as we come well, as we come into the new administration, hopefully coming out of the pandemic, I think they'll still, on day one, need to, as we all know, need to be addressing the issues associated, and hopefully, and I believe there'll be concerted attention to what will the behavioral health needs be related to the pandemic for the social isolation, the lost learning, the undetected child abuse, domestic violence that we've now endured for, well, by that time it will be 10 months, and creating some mechanisms to reach out to communities to help address those issues of exacerbated conditions, because otherwise I think we'll have a slippery slope of increasing demand without increasing capacity. Further integration, BH and PH, it's been a longstanding issue. I think as we have a greater push around things like the collaborative care model, things like ESPER, I think we'll hopefully get better uptake as we make a better use of our health system in general through telehealth and other technologies, better use of analytics, predictive analytics. I think as we move toward value-based care, I think that will be an inevitability that we're going to have to use our data better, have to move toward measurement-based care. And then addressing unmet health-related basic needs. I think that's our fancy way of talking about social determinants. We're making the point that it's not determinative, but that these are and I would expand that it's not just jobs and transportation and food, but it's also the social connectedness, the relationships, the inclusion, the recovery support that we know that people need and benefit from, and then equity. As I'm sure everyone has been monitoring how the appointments have been going, I think that's just a great indicator of how important the reducing racial and ethnic disparities in healthcare will be, and certainly in behavioral health, we have even starker disparities and greater opportunities for improvement. And then investing in BH at parity, as has been discussed. And next page, we have done some cost projections. If you look at the next page, where if we look across systems, if we implemented what we know works, if we brought BH providers at parity, we improved our networks, we adequately addressed crisis care, we brought people to appropriate sites of care when they were in crisis, that we could save upwards of $185 billion in relative to what current expenditures are when we get to a run rate of effectiveness. And it's a 3-to-1 investment of what we would need to be put down as investments in infrastructure and workforce, and that would be the potential savings. Well, most of that savings is obviously in the physical healthcare space versus behavioral health, but super opportunity and certainly a waste if we're not doing it. Next slide. And I know there's a lot of well-deserved focus, and because of making up for years of a lack of focus on the high-need populations with complex healthcare conditions, complex behavioral health conditions. Certainly, we need to continue to do all we can to treat those populations well, but we cannot let the gas off the pedal up at all on looking at our community populations of mild to moderate, or people who have a diagnosis but are not in treatment, because we see in the data that the people who are in the high, sort of in that bright blue corner in 1 year, about 50% of them came from a different category the previous year. So about 25% of those people who all of a sudden are in a high complexity, high cost behavioral health condition were not getting any treatment the year before. And then another 25% were in a lower category. And so the movement across these and the resulting kind of human cost and economic cost are tremendous. And we need to put the policies in place and the programs in place across the board to be preventive, to do early intervention, as well as to do wraparound evidence-based care, trauma-informed care for those that are at highest need. so that we can support them, help them achieve recovery and stay there, so that they don't experience loss and lost productivity, lost opportunity, and loss of life when we know that we could be doing better. That is it. Thanks. Toss it back to you, Ben.
Awesome. Thanks, Kana. And if I could just ask David and Jane to turn their cameras on. Kana, we've got a bunch of questions that have come in, some public, some private. And I want to start with you just because you finished up here. I think everyone right now is tracking what's happening in Congress. And what we've seen is that there have been potentially some dollars that could go towards mental health and addiction. No one's seen the final language of the bill yet, so we're still kind of guesstimating here. But clearly there are complex politics governing that bill. What do you think about the need for congressional action versus more administrative policy change? And I don't mean for you to speculate on what might happen within the Senate over the next month with the runoff election in Georgia, but just there are very different levers that we can use in government to really make a huge impact. So what is your take on kind of what's happening now and the congressional action versus the administrative policies that could potentially be changed or modified for mental health? Any takes or insights there?
You know, I mean, I think there's always more that could be done, and I would feel more pressure around congressional action if we'd really maximized everything we needed to do with the flexibilities, the authorities that we currently have. You know, I mean, we're not enforcing parity in the level that we're already authorized to do, right? And we're not necessarily convening and leading and partnering with states and payers to see through parity in a way that is clear and decisive. So, you know, there's opportunities to do that. I think we have. I mean, there's also pretty significant opportunity in what at least like SAMHSA and CDC can do with respect to work in BH. It's really about political will and the appropriations, more or less. And then I think we can be doing more with CMS. I mean, they already have great flexibilities. I mean, you could come up with yet another demo program or pilot authority, but you know, we haven't scaled some of the things that we already know work. So I think that's there. And so not to diss anyone who is pushing a bill. I'm sure it's a great bill, and I'm sure it will bring great things. But I think it can't be launch and leave. You know, you can't like get the bill passed and then I guess the executive, you know, branch is going to take care of it. Like it's got to get, the executive branch will continue to need support because they will need the resources, they will need the staff, they will need the collaboration from others to really make change happen on the ground.
Thanks for that. Jane, yeah, please go ahead, Jane.
Yeah, I just wanted to follow up. Kana, I absolutely agree. Just in terms of flexibility of programs that are already there, the grant that Washington State got to do our behavioral health group or our behavioral health work is a grant, a broad sort of state flexibility to implement the ACA grant program. And we asked if we could focus in on behavioral health services, and CMS said absolutely. And there's a cycle 2 funding opportunity out there right now for state Department of Insurance. And we're about to submit a letter of intent so that we can continue our work. And I do absolutely want to endorse what Kana said about resources. I don't think anybody on this call would disagree that MPA is a pretty complex piece of law. And the resources that are needed not only for states, but also for private purchasers to dig in and really understand how their third-party administrators and insurers are implementing parity and complying with parity. It's very resource intensive. The same for DOL and EBSA and their efforts to do oversight compliance with self-funded plans. It's critically important work, but it also takes a lot of resources to do it.
Yeah, and I'll just echo that in terms of you know, parity enforcement is really, you know, quite an involved process, and you need resources, and the Department of Labor and both CMS have not you know, can make it more of a priority, but also need more resources to do so. So that's critically important. I think it's also important, you know, with respect to coverage, is getting away from the fee-for-service model that we continue to rely on, and having alternative payment models, that we're developing, because the way we pay for coverage right now and care is really is really not a recipe for success in the long term. So I think there's a lot to be done there, and I think CMS in particular can can advance these APMs, particularly in behavioral health, where we haven't seen as much progress as with on the physical health side.
Yeah, well said, well said. Death to fee for service is the bumper sticker on my car. So I think I agree with you on that one, David. We've got a lot of things that have come in, and I'm going to try and organize these just briefly. Jane, one of the questions that came up to you specifically was if you could talk a little bit more about what a market conduct fully entails. Because I think one of the tensions that you highlighted was around regulation, which is important, but we know this takes time, resources, and sometimes can lead to political polarization. I'm just curious, like, how can you describe a little bit more about that? As you were describing it to me and on the webinar, it seemed like there's a lot more you could say there. I'm just wondering if maybe you can give our folks who are watching just a little bit more around that market conduct and what that means.
Okay, so the concept of market conduct is essentially the responsibility that state insurance regulators have to make sure that insurers are complying with the law. And in this case, we have the ability to enforce both federal MPIA statutes and also state laws, state mental health parity statutes. And a number of states that have recently taken action have done full-blown what we call market conduct examinations. They take years to do, and they are very, very involved and detailed. And they often, because they take a long time to do, when they're done, they may be relying upon claims data and work that the insurer was actually doing 3 years ago. And they often, as I indicated, a number of the states that I mentioned have just issued market conduct exam reports. Those are public reports. They say, here's where we saw the deficiencies, here are the penalties that we're assessing, and here is the compliance plan that the insurers agree to. The work that we're doing in Washington State, we're doing under our Market Conduct Authority. But what we ended up deciding was, rather than doing a full-blown, big, massive market conduct exam around all of parity, we took what we heard from the clinical experts that we partnered with at the University of Washington, from providers, from consumers, and from our initial oversight work. And we said, where do we need to really focus on this next round? So in our second market scan, we focused on provider credentialing, reimbursement rates, prior authorization for inpatient services, concurrent review for inpatient and outpatient. The places where we perceive that providers have the most barriers to actually joining networks and providing services, and the places where consumers are most likely to hit denial. So we just thought, and we actually had a lot of discussion with Henry Harbin to talk about how we could make this as effective as possible. So that's how we approached it.
Thank you. That's very helpful, and I think useful for folks that aren't as in the weeds as you are on this. David, I want to come back to you for a second, because another one of the questions came up around these successes that seemingly have happened with mental health parity. We had the WIT versus United, and now you've got SB 855 in California. Where do you see things going from there? And I open this up to Kana and Jane too from their perspectives, but it seems like that you've got model legislation that you launched today. You've got some interest and some excitement, but you're building momentum, my friend. Where are things going to go next, and where do you see this ultimately ending?
Well, I mean, we'd love additional states to follow, California's lead, and also New York State's been doing, quite a bit through the Office of Mental Health, relating to the criteria and guidelines that plans are using. And actually, New York law now requires that all mental health criteria be approved by the Office of Mental Health, and against guiding principles that the Office of Mental Health has put out. And those principles are consistent with these generally accepted standards of care. And my understanding is that every single plan in New York, both Medicaid, MCO, and commercial, had their criteria, their mental health criteria, rejected by the state. And so that process is playing out right now. And so what New York State is doing, I think will really have potentially a major effect. California is just kind of beginning with its new requirements that actually haven't even taken effect yet. They take effect on January 1st. So certainly more states should be following the lead of California and New York. And federally, these same requirements should be in place federally for all plans in both commercial and Medicaid MCOs. And that could certainly be done through legislation. There may even be a regulatory route through DOL. So I think that those are conversations that we look forward to having with the new administration. But we think that this, to advance parity, you actually can't always be looking at what is happening on the physical health side and just trying to prove that there's discrimination. I mean, we see in an equity kind of context more broadly in society that there's a difference between kind of equal treatment and equitable treatment. And I think we need to be looking at that in behavioral health, and Kana's amazing slides. As an aside, I'm always having slides next to McKinsey slides. They're always you're always inferior, but this is definitely where we should be going. But we need to make advancements in coverage generally, in pushing for make sure everyone's covered, and that also we're covering services like crisis care, which are not actually covered by commercial insurance by and large, which is amazing to me that we don't have a crisis system. We have a new 988 number that's coming into effect, and we're only talking about how basically taxpayers can pay for these services, and nowhere in the discussion is what commercial insurers, how they should be paying for crisis response services.
Let's hang with the insurers for a second here. And I'm going to read a question that came into the Q&A, and Kana and Jade, maybe this can come to you first. I'm going to read it almost verbatim because it's brilliant, and it's from one of our radically disruptive economist friends. They say there is a stark contrast between the economic case for more mental health parity / spending that the McKinsey slide shows versus the current payment rates for mental health professionals versus primary care med-surg physicians. Do plans not believe the economic case, or are 1970 actuarial views about Woody Allen mental health visits still prevalent, or is it both? And I leave that to both of you. It's a great question.
Kana, why don't you start?
I am finding really receptive audiences. I mean, there's kind of just a market economics thing that makes sense to folks. They can see that they don't have adequate networks, or I wouldn't say adequate. They hear that people are having a hard time accessing care in network. They know that people are challenged to get providers without having to pay out of pocket. And so, we've done some comparisons. Some plans are paying 50% of Medicare for a BH visit, which and initially it's true, they didn't believe that that psychiatry, for example, 15-minute E&M was reimbursed at a lower rate than Medicare. They're like, all specialists are, even primary care is reimbursed above Medicare. I was like, that's not what our data say, but we can check, and then it's like, 50% of Medicare. Well, there you are. You can understand why your network is not great and why these folks are driving 50% of your healthcare costs. So I'm finding receptive audience. Have we found a solution to it? Have people, you see Blue Cross Blue Shield Massachusetts doubling down on the rate that they're offering child psychiatrists. And so, if we increase our rate to child psychiatrists by 50%, then lo and behold, they've got most of the child psychiatrists in the state in network. So it can work if folks put their mind to it.
And I think I agree, and I would add to that, for the first time, folks might know that the Department of Labor has an MPIA self-compliance checklist tool. And for the first time, their 2020 tool talks about provider reimbursement as a non-quantitative treatment limitation, and calls out differences in provider reimbursement as a red flag. And we indeed found in ours that there is a difference in provider reimbursement, and we are calling it out to the carriers, and we are basically going to be going back and talking to them about it. I think when we think about sort of what the behavioral health provider world looks like and what the med-surg provider world looks like, there's more consolidation, there's more concentration on the med-surg side. And when you have more hospitals and providers negotiating as a massive group, especially in states like Washington, where we have pretty strict network adequacy standards, it gives those big systems a lot of leverage in negotiating with healthcare, with insurers. And the behavioral health world is sort of different. It's more, especially sort of at like the clinical social worker level, more independent practitioners. And so in the real world, part of it might be just questions about who's got sort of bargaining leverage, but nothing is an excuse for the fact that the insurers have to have an adequate provider network, and that hopefully more and more states are going to be looking at how many of those providers are actually taking care of folks.
Really helpful.
And you see more and more movement towards provider consolidation, whether it's even on nonprofit and the for-profit side. So there's fewer of the onesie twosie mom and pop shops, and so that will increase the leverage of the providers to negotiate, like you said. So a lot of movement there.
The only other thing I might point out is the carve-outs can actually, in my view, be problematic because you have essentially a separate P&L. And so where you have people within organizations make decisions that will kind of maximize the outcomes for themselves and the organization that they're operating within. So if you have a separate carve-out, the incentive is to reduce behavioral health spend because you're never going to see any of the positive externalities that occur on the physical health side. Instead, you're just trying to maximize your own little world. So I think that's actually an important issue.
Well said, David. And I think we could spend
I think it could depend on the carve-out.
Yeah, I was going to say we could spend another couple hours talking about the carve-in, carve-out debate there. It's really a big one. So just in our last couple of minutes here, I want to throw one more question to all three of you and maybe take 15 to 30 seconds to reply. What gives you hope in 2021? We have a new year. 2020, I think, for the most part, has been pretty bad for a lot of folks. 2021 holds hope and promise. What do you all have hope for mental health and policy in the new year? And we'll just start in the order that we went today. So David?
Sure. I mean, I have a lot of hope. Obviously, COVID will hopefully be under control relatively soon. And we have major mental health challenges that we need to meet. But I think both policymakers at state and federal level increasingly understand the importance of these issues, and having these issues be a priority is critically important, because if they're not a priority, we won't make any progress at all. So I think that's really key. And also, a lot of the advocates are increasingly, coordinating their activities in a way that I think, hasn't been done before, which is extremely positive. So that gives me a lot of hope.
So a couple of things give me hope from my insurance regulator world. The incredible interest that we've seen among the states in really stepping up and getting more engaged on parity compliance work, I think is really positive. And the other thing that, COVID's been absolutely horrible, and we all look for tiny little things that are helpful. And the emergence and the increased use of telebehavioral health. And one of the beauties of telebehavioral health is that we actually have the evidence to show that it's effective for treatment of depression, anxiety, PTSD. And so the expectation, I think, is that even in a post-COVID world, there'll be more telebehavioral health services. So that's a good thing.
So for as difficult a year as it has been for all of us, what gives me hope is the activation, the motivation, and the engagement of our young people. I think we, although they're facing more struggles, more emotional health challenges than ever before, I think they're also, this is a generation that sees behavioral health as part of health. And so unlike where we were, and having to fight for parity or not understanding why things were so inequitable in the past. This is a generation that this is how they're going to choose their jobs. It's how they're going to choose their health plans. They're going to demand it. And so that gives me hope, because I think that's the paradigm shift, that's the social shift we need to see the progress that we all are working so hard for.
Well, you three give me hope. Thank you. Thanks for coming on to this today and weighing in with your expertise on a topic that I know is pretty heavy that we could spend several hours talking through. Thanks to everybody else for joining us today. We will look forward to having this posted on the website for you to share with your friends who were not able to join us today. And we will begin the series again in January for more insights around mental health and policy. So thanks again, David, Kana, and Jane. Really appreciate it. And everybody, Happy New Year and happy holidays.